Bologna Guidelines for Adhesive Small Bowel Obstruction, ASBO, your go-to summary on ASBO. Hey everyone, welcome back to the channel. Today, we're diving into something a little different, a set of medical recommendations you might have heard of, the Bologna Guidelines for Adhesive Small Bowel Obstruction, or ASBO for short. So, let's set the scene. ASBO is a pretty common complication after abdominal surgery, and the Bologna Guidelines, published back in 2017, give us a roadmap for how to tackle it. Let's break it down step by step. 1. First up, diagnosis. What are we looking for? Colicky, abdominal pain, vomiting, abdominal distension, obstipation, which basically means you can't pass stool or gas, and on exam, you might hear those classic high-pitched bowel sounds, or see a tympanic, drum-like abdomen. If things get really serious and you suspect strangulation, you'll see more tenderness. Imaging? Here's the deal. CT scan is the gold standard. This is what will really show you what's going on, like where the blockage is, if the bowel is still healthy, and if there are any complications. X-rays? They're less sensitive, but sometimes you'll see dilated loops or air fluid levels too. Initial management. What do we do first? If the patient is stable, meaning no signs of peritonitis or bowel death, here's the playbook. NPO. Nothing by mouth. Comma, stick in a nasogastric tube for decompression. Start IV fluids and correct any electrolyte imbalances. And here's a cool trick. Do a water-soluble contrast challenge using gastrographin. If the contrast makes its way to the colon in 24 hours, there's a good chance you won't need surgery. But if the patient is unstable, think peritonitis or suspected strangulation, it's straight to emergency surgery. 3. Non-operative management. NOM. Did you know that up to 70 to 90% of partial obstructions can clear up without surgery? That's great news. But watch out. If symptoms get worse, there's fever, rising white count, or no improvement in 48 to 72 hours, it's time to escalate for surgery. When is it necessary? You'll need to operate if there's peritonitis, bowel ischemia, perforation, or if non-operative management just isn't working, especially with complete obstruction. The approach could be laparoscopy, if the doctor is skilled and there aren't too many adhesions, or open surgery, with removal of dead bowel if needed. 5. Prevention. How do we keep this from happening again? Some tips. Use anti-adhesive barriers, like certain films, during surgery. Encourage early mobilization and choose minimally invasive surgery when possible. To wrap up, here are your key takeaways. CT is the gold standard for diagnosis. Stable patients? Try non-operative management with gastrographin. Surgery is a must if there are signs of strangulation or if non-op management fails. Laparoscopy is an option in select cases. And that's a wrap, folks. If you found this breakdown helpful, don't forget to like, subscribe, and drop your questions in the comments below. Stay curious and see you next time on the Everything Surgery podcast. Dissect the extraordinary.